This is a special day at NAPCRG. For the first time, I believe, we're having two plenaries, two very distinguished speakers and panels. And I'd like to introduce Dr. Amanda Howe. She is a practicing family doctor, an academic professor, and a national and international leader in family medicine. Since 2001, she's been professor of primary care at the University of East Anglia in England, where she was part of the founding team for the new medical program. During her career, she's had multiple roles in undergraduate, graduate, and faculty education. Dr. Howe's particular expertise is in the teaching and learning of professionalism and patient safety, in the models and effectiveness of involving family medicine in community-based medical education, and in resilience and doctors' well-being, a particularly important issue nowadays. She also has clinical research interests in primary care mental health, the contribution of patients to healthcare, and in early interventions for risk factors. From 2009 to 2015, she served as an officer for the Royal College of General Practitioners. She previously chaired their research committee, and she was also chair of the UK Society for Academic Primary Care, the English equivalent to NAPCRG, if you will. She's currently president of the World Organization of Family Doctors, also known as WONCA. Welcome, Dr. Howe.
Thank you very much. Now I remember that I was going to have a lapel mic so that you could actually see me, but maybe I can do it like this. Bonjour, chers collègues. I am really happy to be here in Canada, and it's a privilege for me to be speaking with you about the work of WONCA and reflecting for this talk on some of the issues that I think many of us in academic primary care have been reflecting on all our lives. It's a pleasure for me to see in the audience many colleagues actually from my community in the UK, and hopefully we'll be able to carry on some of these discussions when we're back that side. It's also been a wonderful experience for me to actually be in Canada for totally a 12-day trip, because I was also invited to speak at the Canadian College, and then I've done some academic visits in Queen's and University of Toronto. And I've learned a lot, and it's made me think a lot. I've given talks about advocacy, I've given talk about systems and the barriers to establishing family medicine, and in the process of having those learning conversations, I myself have continued to think and reflect. So hopefully this talk will take us a little further in a journey together and will be productive for the future of academic primary care research. So, this was the title that somehow we chose, and I'm grateful to Mark Abel and Jen DeVoe for, helping me to come here and choose this title. And I'll see if I can work. Just to tell you, for those of you who don't know about WONCA, one thing people keep asking me is, how does the World Organization of Family Doctors work out to be WONCA? And it was initially inaugurated as the World Organization of National Congresses and Assemblies of Family Medicine, hence the acronym. And when Roald Dahl wrote his famous book, we particularly didn't want to give it up. It's a membership organization. So we organize ourselves in global 7 regions, more or less like WHO, Europe, Africa, North America, Ibero-America, Middle East, Asia, Asia-Pacific. You join as a member organization, so the Royal College of GPs, the Canadian College of Family Physicians, the American Academy, the Society of Teachers of Family Medicine. If you've got an incorporated body that meets the needs, you can join. We're currently at 151 countries, and we have other types of membership as well, so academic membership, direct membership. So for countries who don't have family medicine, but where people, already identifying with the discipline and its potential, there's other ways of being in our network. And we are a registered non-state actor NGO with the WHO for the purposes of our learning and information, but also advocacy, and we're growing all the time. So, Chris Van Weel, respect to my past president who is here, Michael Kidd, who I saw in Toronto last week, but is currently somewhere else in the world. We can see that things have been growing throughout the work of WONCA, and that's great to see because it reflects family medicine. And the mission of WONCA is, in fact, to improve the quality of life of the peoples of the world. So our mission is not about making life easy for doctors or our own members. We do believe that family medicine is a core route in the medical workforce for improving the quality of care that people get. We stand for high standards, for a comprehensive, personalised, continuing care package. We have equity in our mission statement, so that is a big challenge in this world, and we'll talk about that more in my specifics of this talk. We see our academic colleagues in the academic organisations as absolutely core to growing the discipline, improving the evidence base, leading the generations of tomorrow, and reaching out to colleagues with less capacity than themselves in order to grow the discipline worldwide. Exchanging views, exchanging knowledge, ideas, learning from each other, and again, being a representative. So that's the mission. And I think we also usually need to remind ourselves what we mean about the work of a family doctor. So if we're talking about research that draws on primary care and potentially the medical work in that workforce, we talk about this definition. And as we discussed at my talk at UT earlier in the week, this may not be manifest in its full scope in every country, in every setting, all the time. But when we're taking the vision of the work that a family doctor can do, this is the definition and the service. And the picture at the bottom is my current executive, who, as you can see, are a global community, and I rely on them to feed back to me about whether this definition works in their place and whether the vision is coming forward in their region. But now I'm going to switch to my reflection about, so we have a world of opportunity. You know, if you're a generalist, it's pretty hard to exclude almost any component from its potential. I'll give you an example, my colleague won't mind. In my department, I have some clinicians, but I also have a whole group of health service researchers, health economics, epidemiologists, statistics, social scientists. And we have a theme on aging and healthy aging in our medical school in the faculty. And one of my colleagues came to me a few years ago and said, I want to do this project on dancing and dementia. So I looked down our programs of work and I was like, really? Which program are we building on here? How does that fit with the work you've been doing before? All the horrible straight questions that professors have to test with their colleagues. And she gave me a case, and you know, guess what? Now in my community anyway, you play a tune and people who don't remember very much else remember the tune and they stand up and dance. And so she was actually onto something. I don't know how I could have known then that that was going to be helpful. I often think about that when people come to me with new ideas and I don't think they fit. I think, can I really say no? I'm not sure. Of course, you go back to the evidence. Of course, you go back to what the community think might help. And this was actually a community-driven idea. So, but I think our discipline, and indeed if you broaden that to primary care, if you broaden that to all the communities, again, wonderful plenary first thing this morning, you know, about, you know, what the people think might be helpful and relevant to them. And if you take that globally, that's an awfully big agenda. Hence my question about a world of opportunity. But how do we choose? So I looked back for the sake of this talk to what gets funded. And, you know, I haven't done a systematic literature research on this one, but here are just a few examples. We'll do some categories. Generally, I find things split into this. There's basic research concerned with the understanding of mechanisms. User-led or lab-to-bedside translational, we might call, you know, how do you move that through to something that might apply, and then applied work in, you know, clinical setting, and PS, in this definition, health services and systems. So there's not a lot in that definition, but imbued in the last one is, you know, what patients want, what's the patient's experience, what's the behavior, what's the system doing with the knowledge that we've got. And in my UK examples, just a couple of things here. What gets funded? There's a shift. I'm taking a particular year, but basic research was 68%, so over two-thirds of the funding in that, you know, blue skies, pre-applied sector, dropped a bit, lab to bedside went up a bit, and applied went up a bit less. So the sector that I've done my research in, whether it's, you know, PPI, medical education, quality, patient safety, still a small proportion of the funding that travels through. In 2014, the UK Clinical Research Collaboration shows it's about 8.5 billion. Some shift again, pharmaceutical industry sponsorship was shifting during this time, a bit more applied research with big global priorities like antimicrobial resistance. But again, if we look at these figures very briefly, just as an example, and I guess all your countries will have parallel figures, and I think we'll still see that the basic research, science research, bioscience research dominates. The applied end is at the minority spectrum, and often even then, you know, you can't identify what was primary care research. You can't identify the setting that we're generally talking about or indeed working in. Then the question about how research priorities are set. So you all have been experienced at some point, I'm sure, in sitting around a table or being online doing a Delphi survey about, you know, what priorities should go where. Several reviews in the literature on this. One in 2016 showed that this is becoming a common sport, you know, and particularly in my country, your two countries in this region, and Australia. We seem to be re-examining our navels on this one fairly frequently. Some of them had global scope, some of them concentrated on high-income countries, and some of them concentrated on lower-income countries. So quite a good mix there. People question the methods. What works best? Some of you may have technical knowledge in this, and that would be interesting to share. Should we have a gold standard approach to priority setting? One size usually doesn't fit all, in my opinion, especially in a worldwide context. You know, and again, the plenary this morning, how do you fit that in? Each community is going to have its own ideas and so on. But still, you know, is there a process that is robust? And some of the criteria that people put across for research priorities are these. Must be contextualized. What context are you talking about the prioritization for or with? A comprehensive and inclusive approach, looking at the big picture of needs and opportunities, involving relevant stakeholders, not neglecting prior work, not reinventing the wheel, and planning the implementation cycle. Of course, we would say that as academics, very important that you're clear what you're going to do, how you're going to do it, that the methods fit, and then actually being committed to the impact of the findings, and perhaps even repeating them. And it was interesting in the literature to say how many times people had done a review, but then you couldn't find out what had happened afterwards. And it certainly didn't seem to have stuck to say 5 years later, where are we now? And a lot of that, I think, is process, not content. So again, I'm there looking for something that says, and we must do more in primary care, or we must do more in lower income countries. And actually, they're not saying that. They're saying this is the way to do it. Often when we are looking at the LMEC literature, it was being done by external agencies. So rather having ownership in the countries themselves, the institutions themselves, the peoples of those countries, it was something like UNAID or WHO or a charitable group. And that may be fine, but again, it's sort of, how does that work? What's the ownership of that? And beyond that, there was a big discussion a few years ago through the Lancet about whether the priorities that were being set and the way that the funding was traveling actually was resulting in really good research. Was it the research that was needed? Were the findings actually getting published? Or were there biases at play through the sources of funding and the prior knowledge of the experienced upper-end research communities towards certain types of research that were less valuable in terms of policy health implementation? And a few references there if you need them. Now, I was part of a conference here, 2003, as were 7 other people in the room, and the big question was being asked, what should we be doing in academic primary care? And these were the recommendations of the Kingston Conference. I'll just let you read through them. I guess you can say that my discipline, like others working in primary care, one of my colleagues, nurse practitioners in the UK or pharmacists in the UK, was still growing the disciplines that work in primary care and the way we work with other non-clinical colleagues who underpin and make our research possible. So we're still relatively new, but Kingston, we were saying, we ought to be bringing all this together. We ought to be using it systematically. We need to make sure that it travels into the policy domain. We need to be sure that we're looking at population health and so on. What I also thought when I read this good set of recommendations, that again, you can think that's what an academic discipline worldwide needs to be trying to do. I also find myself thinking, well, what's missing? And what's new since then? Certainly on those headlines, there's not a lot of explicit reference to the sort of discussion that the colleagues on the panel this morning were championing about the voice of the patient, the voice of the people, the role of the community, and the orientation to ownership by the people of the sort of research we do. But the last recommendation about the needs of developing countries was in there then, and quite right. NAPCRG also has had a look at this. I'm sure you've all take this to bed with you and keep it on your table by your bedside. Where should we be? Must be done. Research priorities must be done in primary care settings, preferably using the networks that we've tried to build up and bring together. Need for capacity building in our place, I hope, and I'll come back to that, in other countries as well. And a focus on practice transformation, the health services side, what will improve the care that we offer? And there were 3 particular domains that were highlighted in that short editorial: quality and safety, multimorbidity, and integrating the psychosocial approaches to care to complement drug-based and more mechanistic technical interventions. So, good examples of where we thought our discipline was growing. Now, the next 3 slides are, so what does good look like? And declaration of interest, this book, I was part of the editorial team. We asked colleagues around the world to choose a classic paper and review it, to tell us why they thought it really mattered and what it told us about things that mattered to patients about family medicine. Some of the papers got nicked pretty quickly. At least I put one forward. Oh no, somebody's already said that. I put another one forward. Oh no, somebody's already said that. So we had a sort of hierarchy, but fantastic work and a fantastic, exciting opportunity with the reviewers to see what they chose. And some classic papers are in there, to name but a few. Please have a look. So what good looks like to us, we've got a rich terrain. We've got fantastic work that's been going on right up to the present day, and you know what it looks like when you find it. Another way to think about what is good is what's the profession choosing. So this was an academic, if you like, choosing from academic papers. Top 20 research studies, 2016, Mark did this in, I think again in Annals, chose clinical stuff, what's going to matter to the clinicians, and these were some of the papers that hit up that seemed relevant for our practice. And my own college, again, the papers of the year last year, very clinical: polymyalgia rheumatica, UTI, COPD. So what good looks like when you're a clinician and you want to know what the new evidence tells you may be a little different than what the academics would feel have influenced the growth of the discipline over time, or influenced our teaching, or whatever. My most cited article, that when you go on and you see in a sad moment how many hits you're getting for what, is not a randomized clinical trial. It's not a literature review. It's a little discussion paper that came out of me hearing clinical psychologists teaching my students about resilience. And I thought, that's a concept with credibility and face validity. I'm going to read about that. And again, my two social science colleagues, we had a quick look round, pulled some literature up, and I wrote an article about how we might apply the learning of how to be resilient in a medical education context. And it's still getting loads of hits. So fascinating. What good looks like to the people who come online isn't what my dean thinks I should be putting into the research excellence. And then you go on the internet. So I thought, well, I'll ask online, what are the big hitters? And I came up with this from the Times Higher Education Supplement, which is not an academic journal, but it's a very credible offshoot of the Times journal in our country that looks at the higher education sector. And it came up with, in the first 20, these were the ones that had a health theme. First one was written by Obama, I think after he handed on. And people, trying to keep the question of the healthcare, that was getting the most hits in the altmetric ranking. And there were some really wacky things in the top 20 as well, which I promised myself when I stopped being president and I have a life again. I'm going to look up the terrorist inside my husband's brain. But these things were actually, no, this is, the stuff that people were reading online, and they are all quite serious articles. So I think, again, the question of what good looks like, is it what you're interested in? Is it how many hits? The internet is going to change the way publishing works, isn't it? Why would we, the whole thing about accessibility and what gets read and what gets shared through social media. So I guess the point of these 3 slides is good research and priorities, again, look different from different perspectives. Who's reading, where they're reading it, why they're reading it, what they think it means. So then I found myself saying, okay, Amanda, you're talking about WONCA. That's the point of being up at NAPCRG. So if I'm talking about global academic primary care and getting some sort of list of what would matter there, what would that look like? Not for the UK, not for what my government thinks the priorities are, not what my university thinks the priorities are, not what I'm interested in, not what my patients are interested in, but actually the global sense. That's the job I do right now. If I was saying this is what matters around the world, can we make ourselves more globally aware as academics, what would the priority checklist look like? I think it would look like this. These are people working in different healthcare settings, in different parts of the globe, doing different jobs. There's a community health worker, there's some doctors, there's a medical student, there's an unqualified person giving out healthcare on the street, trying to help his local community because that's accessible and affordable, and he does it over time. 3 of the criteria that we think matter. Or it might look like this. The care that would actually make a difference to the lives of these people, wherever they live in the world, whatever age they are, and whatever their different incomes and opportunities are, and their comorbidities and health risks. Let's keep them in our mind. So, another article, do the research priorities that are being set up match global health? Now, this is a little old, this article. Didn't have time to look for a more modern one, but I think the points hold together. Less than 10% of worldwide health research is devoted to diseases that account for 90% of the global burden of disease. It's a bit like the statistics about Africa, which has 80% of the global burden of disease, 3% of the workforce and 1% of the health expenditure, those sorts of big equity gap, right? And if you were going to prioritize, do you choose to research the issues that would reduce the burden of global disease? Or let your research agenda be informed by the priorities of lower income and developing countries? Or have an explicit aim that what you want to do with your research is going to reduce the equity gap? And okay, we don't always know how trials are going to come out or studies are going to come out, but at least having that lens from the beginning. I'm choosing this because there's an equity gap closure opportunity here. Research that solidly engages civil society, I think that's a posh way of saying what we heard this morning, where actually part of the process really draws in, engages with before, during, and after the community. And my colleague Anthony Tutor, who did work with me in the college, delighted to see her in the front row, always championing, don't set your research up, Amanda, and then tell us you're going to do it and ask what we think. Bring us in at the beginning, have us there at the end, and be a partner. And increasing the equity of knowledge capacity, so also really aiming that in the process of doing our research, we will build capacity. We often think about that for the next generation of academic researchers, clinical and non-clinical. I'm not sure I've always thought about, if I'm going to put a PhD into this grant, could I be giving it to somebody coming from another country or letting them do the work in that country rather than recruiting one of my own? So those are some of the things that I think we need to consider. So now I've got a wish list, and you'll notice that I've taken the WONCA stamp off this because this is personal. I've just started another journey through this talk. It's not that it will be totally new or novel, because good ideas come round again, but I was just, reflecting, I was thinking, so this is some of the stuff that I would really like, whether the funders are from government, whether they're charities, or whether they're industry partners, because some people are doing research with industry partners, and in some settings that may be quite appropriate. But can you make sure that you're referencing your funding to include studies in the primary care setting that have significant importance? Again, that trend where we don't know. I mean, a colleague of mine, again, did some work on guidelines. We looked at the guidelines and how much of the research that was being recommended for use in clinical primary care had actually been conducted in primary care. And the answer, and you can see our publications on this, remarkably little. So, let's ask the funders, and how much money are you going to give to studies? How much money have you given to studies that are happening in the community setting, not in the hospital setting? How much of your budget is allocated to applied research, to HSR, to the community end of the spectrum? And I might be talking about epidemiology, but actually I'm not talking just about epidemiology. Or is the bulk of your funding going to the bioscience end? How are you engaging with the primary healthcare community to show that those findings count? So when the work's done, what can you show us about dissemination, application? Now, again, that's something that we are being pushed on in my country, but it's sometimes a little bit tick box. So, well, yes, I sent that report to the, local stakeholders. It's not that I really went out and grappled with the local funders to say, we need a change in the services here, guys. And calling on the funders to address that application, and then that the bid criteria should prioritize global health priorities and should include international partnerships and academic capacity building. Just a thought, funders. And then to ourselves, again, let's talk about the issues that really matter for global health, for our communities, be aware of the global dimensions, the equity, the priorities, the capacity building. And start, it's not that it doesn't have a payback for us. We learn a lot. We can show journals that we have international engagement in our studies. And we get graduates recruiting in. If you get a PhD funded, you know, it's a place for your institution. So it can be a real win-win. Question of levels of social accountability. This may be a minority sport, but there are international standards that you can take to your own institutions and see how much you feel you are being socially accountable as a medical school or as a faculty of health science. And then, again, professional leaders like me, challenge myself, pushing back on the funding priorities. I haven't been spending much time doing that recently, but this has made me think again. And changing the paradigm. So again, I'm a qualitative social science researcher myself. That's the discipline that I really developed my methodological skills in. And, you know, as a medical educationalist, as a qualitative researcher, but as community-oriented primary care, the discussion we were having with the panel, you know, who funds that really? Or is it the new genome? Or is it the lookalike drug from some other setting? So the paradigm shift towards global health, towards more user-led research, towards more implementation research, I think still is not there. It's still a very small funding body, and that's where one of the pushes that I'm really encouraging us to think about. Sometimes governments are beginning to align their funding with development monies and indeed with research. We've seen that a little bit in the UK recently. I think we should really support that because it gives us some new opportunities, some new incentives, and some new encouragement to do the sort of global health awareness push that I'm talking about, and perhaps even to have national and international policies on these issues. And I'm sure many Canadians in the room are thinking, we've got that already. And maybe, yes, maybe your country is leading on this because, you know, to have those explicit goals then influences funding, it influences institutions, it influences the opportunities, and it influences the openness to bring colleagues from another country to work at your place, which can also be a challenge in some settings. Stuff we do then. Let me close on this, just a couple more slides. What do we already try to do? Well, I've told you we champion the academic development of family medicine. We set standards, we try and add resources into the system, using often the skills of our more mature members to travel back into the community as new countries build up. We run scientific conferences. We have a research working party. Felicity Goodyear-Smith's the current chair. I can't see her right now, but she's here somewhere doing a great job following on with Chris in many different activities that are bringing strands of thought together. And if you don't know about that, you know, you're welcome to hear more. And of course, we are active through partnerships such as our one with NAPCRG. And I've seen some good practice in the past little while. I just put a few. In fact, I've seen amazing good practice. Every country I go to, you know, the academics are trying to do a really great job. I'm the first professor of family medicine in Ethiopia with her 7 residents was at the Canadian College last week. Bless her, you know. So the Besra Centre lodged in the Canadian College, this is good practice. Bringing together people who are studying, developing capacity from developing countries, creating a learning set, bringing them in, going back to their countries, not taking them away from their countries, let's be clear. But so, you know, fantastic work there, and that's why the young Ethiopian was at the Canadian College, because of the link with Besra. The Prima for Med network, which I think originally started with Jan de Meissner in Ghent, but has made a huge difference to growing family medicine in Africa, although that's still the biggest challenge regionally in the world, and we need to push on with that and keep that one running forward. The Robert Graham Centre, which the AFP set up, you know, policy centre, lots of good evidence. I often go to the RGC site to try and get documentation for the things that I'm arguing for. The World Health Organization and the Primary Healthcare Performance Initiative, which, you know, again, we were talking about yesterday and has been discussed in other settings, but at least turning the lens to say, well, what's going on in primary care? Yes, Amanda, you're right. We don't have the data. We don't know. We need to know. Let's find out. And a big discussion there about the right measurements and the right indicators, but at least it's something, and WONCA is putting into these groups. We go to Bob Graham for the Starfield Summit, nice of them to ask us, but we do send people. We work with WHO on the PHCPI when we can, and so on and so on. And then we've started bidding. So actually, WONCA has got an academic network, and we've been starting to try and bid through academic partnerships, through WONCA, to actually, again, try and build up some of this momentum and put people in touch that might not otherwise be in touch. So if you're looking for new international partners, please think of, your members, come to us, and maybe we can find people who you can work with. So what are the next steps? Should we revisit the Kingston Consensus, or should we create a new one? With the Research Working Party, we've been discussing what the next programme of work should be, including skilling up family doctors for implementation research or community-oriented participatory research. Where should we put the priority for that work over the next period? Growing the next generation of academic primary healthcare researchers worldwide. I'm sure all of us here are interested in that. We have the Almaty 40th celebration next November. It will be 40 years since the Alma Ata Declaration was launched. And WHO are going to have a big conversation about that, and we really need to be at that table and putting our voice in and making sure that it reflects the priorities of the research community for the next period and for family medicine. And I've been starting to think, and it helped me to be at the Complexity Science Special Interest Group breakfast this morning, even for 5 minutes, about what does blue skies look like in our discipline? Is it shifting the paradigm? Is there something that we need to experiment? There are things we need to experiment with that are hard to get funded. Maybe it's community-oriented work, maybe it's real PPI, maybe it's complexity paradigm, maybe it's my colleagues' dancing and dementia project. Actually, we need to have blue skies funding and blue skies thinking in our community as well as the program grants and the trials and all the stuff. And there are places that you can have these big conversations if this interests you. You've got another NAPCRG next year, no doubt. We've got a global conference in Seoul in mid-October next year. So that's where our whole community gets together and talks about their work across the world. We've also got regional meetings in most of the regions that I put at the bottom, and not just next year, but the year after that and the year after that. So please, let's continue this, and thank you for listening, and thank you to those who invited me, and thank you for all your work, all day, every day. As somebody said this morning, you have to believe in the work. The work is value. It might be 5 years till you get the result. You may never know what that PhD went off and did, but the work in itself matters, and your clinical colleagues and their patients will value that. Thank you very much. Now, do I stay up here and ask people to comment, Mark, while we... Yep, Mark's saying yes. So if anybody wants to go to a mic and comment, join in, ask questions, feel free. I'm just going to get myself a glass of water.
Thanks, Amanda, for your really beautiful review, and thanks for pointing out complexity as a framework to think in a different way about what we are doing and how are we doing things. My comment would be...
Could you just introduce yourself?
Joachim Stormberg. I'm from the Complexity Group. To plug a point, we now have an International Society for Systems and Complexity Sciences for Health, and the 4 is really important in the name of the society.
Thank you.
Coming back to the point I want to make is, in one way, what I felt needed a bit more emphasis is that health is a personal experiential state, and that really the person and his health experience should be one of the key drivers of our thinking in our research effort. I leave that as a comment, and maybe you want to expand on that in one way or another.
Sure. Thank you, Joachim. I think that's exactly the lens, well, it's another of the lenses, and you're right, you know, that wasn't explicitly said in you say things like patient-centered, but it doesn't make that full complexity. And as a researcher, I do find that really challenging to capture that in studies, because as we know, you know, every intervention is going to play a little differently according to the person where the intervention is made. And that's part of the importance of the cultural sensitivity and the testing and all the different methodologies that we can use, funding permitted and will permitted. And of course, it's an even bigger thing if I try and do a study with my colleagues in Kenya and my colleagues in India and my colleagues in the UK, because the systems are very different. So even who we can see and what we can do becomes very complex across a research study. But I completely agree, we need to keep that lens and keep saying, so will this work help us to illuminate that world? And is the paradigm right to do that? Or is it just going to be too technical, too linear, and we won't really understand why that doesn't play out in practice? Now, there was somebody at the mic behind you, but you must have said the right thing for him because he's sat down again. Anybody else? Martin.
Amanda, as you know, I'm a numbers person and you're not a numbers person, but I thought I'd give you a little numbers anecdote.
Do you want to introduce yourself?
I'm sorry, yes. I'm Martin Rowland from the University of Cambridge in the UK. Back in the late 1990s, the UK government set up a commission which David Mant chaired to look at the place of primary care research. And government wanted to know how much of its research spend it was spending on primary care, just the question which you articulated and said was difficult to answer. And I chaired the subgroup which was given this job. So we trawled away, and it was jolly difficult because how did you define primary care and so forth? And the senior civil servant involved kept on emailing me or phoning me up and saying, well, come on, what's the answer? What's the number? And I said, well, it's really very complicated, and we're working on it. And eventually he got so insistent, he said, I need the number tomorrow. So we decided we better come up with a number. So I phoned her back and said, it's 7%. And the next day, he said, well, that's not very much, we'll double it. And the next day, government announced that they would increase primary care research spending to 14%. And they approximately did.
Excellent. Okay. So I think that's a very good example of systems advocacy, and where actually the qualitative sometimes beats the quantitative, because sometimes you just have to be in that place and stand up for what you believe and speak in a voice that the other person can hear. And I'm suggesting, thank you, Martin, I think it's a really good example of where we actually all need to be saying, in a voice that can be heard, this isn't enough. And sometimes the objective evidence isn't the whole story. It's who wants it, whether you're in a position to be heard, and then what you're going to do to drive it forward. And I guess in the bigger picture, that's partly what I'm advocating for it. But sometimes that voice cannot be heard from another country. So the other reason to have a Martin Rowland or an Amanda Howe, whatever, is actually to say, well, you know, maybe your ministry doesn't get this, but here's a voice that they might be able to listen to. Colleague there.
I'm Steve Taplin from the National Cancer Institute in the United States.
Thank you, Steve.
And I wonder if one of the opportunities in this setting is the junction of primary care investigators from very different settings. And I wonder, from where you sit, if you could talk a little bit about the differences in the way funding priorities are set and the way primary care physicians access that funding in the United States and in Canada and in the UK. Just talk a little bit more about your perception from where you sit in WONCA about how we act, how the priorities are set, and how the money is accessed by primary care investigators across these three settings.
Okay. Actually, I don't think that I'm the right person to answer that because I've been spending a lot of energy looking at areas outside the developed world, and I don't know the detail to your question. Can I make even one comment that would be useful? I think what I notice in what I notice talking to colleagues is what my dad would have said, the man that pays the piper calls the tune. So actually, a lot of us at a day-to-day level are looking at where the funding is, trying to match it to the work that's being done, programs of work we're already engaged with, and then trying to design studies that might fit. And I think that's very different between the UK, US, and Canada. I haven't looked at the specific different budgets. So that example I gave of, where the UK money's going, it might well be available. I just haven't looked at that. But maybe Larry's going to tell us the answer. But in terms of actually the problem of saying what's missing or where would we like that funding to be pitched, direct primary care research or primary care researcher led, even if it's on a theme like cancer or cardiovascular or whatever, and even more important for my community, can we spend some of it internationally, bringing people on with us so that not only do we learn about the same problem in another country, but also can we build capacity there? I mean, one more example from the cancer side. So I have David Weller, who's the prof in Edinburgh, who also runs our WONCA Special Interest Group in palliative care, who's done some really excellent international research. And he very deliberately said, I want to conduct this work in countries that are less advantaged. Uganda, and in the process, grew a load of people who knew stuff through the research studies that they didn't know before, so respect for that. But he had to work really hard to find a funder that would let him do that. So that's my comment. Larry? Sorry, okay. I'll look that way. I think Larry's going to comment on the question that was just asked to me, so if I can let him go and then come to you.
Please, if it's related to the question, was just answered, go ahead.
Larry Greene from the University of Colorado School of Medicine in Denver, Colorado, where it's also snowing. Amanda, I'd like to ask you to go back to one of your questions on your slide, just a particular question, and ask your advice and opinion. You said, is it time to have another Kingston conference? Let's just pretend for a moment that the answer to that is yes. How do you suggest that get organized?
So with my forum, I guess what I was thinking yesterday when I wrote that slide was, how would this look different if we had a bigger discussion now? I'm not sure I would do it geographically. I would put out a set of revised questions. I would do it virtually. I would try and get our different members in our different places, building up some ideas, and then we could convene, run it out. So the way we've done it in WONCA Forum is, you run it out. You run it at Kuwait, you run it in Colombia, you run it in Delhi. You try and, over a year or so, have a build. We'd need to do some of the external stakeholder stuff as well, if it was really going to count, and that's where WHO side events and all that stuff comes in. But I think we've got the networks, and maybe through very powerful people in each country, we might also be able to get ministry level. So it would be a longer piece of work with a lot more people, but maybe asking some of the same questions. And again, that's an Amanda Howe statement, that's not a WONCA statement, because I've just started thinking about this. Sorry, Guillaume and then Kate,
Hi, I'm Guillaume
blinded by the
Charbonneau.
light.
I'm the president of the College of Family Physicians of Canada. So my question to you this morning is related to the data ownership and to access to data for research and QI. I would like to have your your opinion and your view about what happened around the world, because we have had some issue recently in Canada. We have encouraged a lot of doctors to take on AMR, and I think we did success in the year ahead, but in the past year. But now we realize that we have given a lot of power to private sector and EMR owner, and we see that they start to charge very large amount of dollar to access data, and we know that data is the water of research and QI. So I think it would be important to do the advocacy for that, and I would like to have your thought about what happened around the world related to that.
Sure, merci. So the electronic medical record, in my experience, in my lifetime in the UK, has been, I think, a better experience than it has been on this side of the Atlantic. And as researchers, we have had many examples of research networks building up ways to bring data from the electronic record in an anonymized form that can be fed into data analyses and be, part of really good research. So as researchers and as a college, actually, we've tried in principle to make sure that there was an alignment between the research opportunities and the development of the electronic medical record, while still protecting the data of the patient, and the patient having, an opt-in to release some of that data, for research purposes. Sometimes that has gone badly under various government initiatives when the faith of the public that the record and their data will be held confidential for clinical purposes has been damaged. That wasn't a problem from our community, but in the process of the public losing faith in that, we've seen people withdrawing permissions and having then to go for opt-in rather than opt-out. Why does the electronic medical record work better for the UK physicians than for the Canadian and the Americans? I'll leave that with you, but I think it's partly because we have a different payer system, and so actually, even though it's complex to fill everything in, it's not as bad as my colleagues are telling me from other countries. So when I was at the AAFP, I went to a workshop about the electronic medical record, and the guy stood at the front, he said, "Hands up, who likes the electronic medical record?" And I went, and I was the only person in the room, and I said, "Oh." And he said, "Where are you from?" And I said, "Oh, the UK." And he said, "That explains it." So I think there's some stuff to say here. But from the research side, I definitely think, and from the QI side, so as a practice, what can I do now? In 2 minutes, Zanti, who is my info tech officer, can tell us how many people haven't been in for their cancer smears in the last 6 months. It used to take me hours and hours and hours to do that study when we had paper records. So whether it's, a community of practice, an individual practice, a student doing a project, this gives us enormous opportunities, providing we're using it for the right reasons, both for clinical and for research. Right, that's my comment. Okay, Kate, thank you.
Amanda, thank you. I really enjoyed your presentation. As well as being at University of Glasgow, I'm here at the moment as the chair of the Society for Academic Primary Care, and I'm well aware of following in the footsteps of giants with yourself, also Roger here and Joanne Reeve. What makes me different, as you know, is that I'm the first primary healthcare scientist to chair SAPC. So I really like the fact that you were acknowledging these whole range of skills that we need in primary care. And then thinking of the global agenda and the research agenda, what can we do to support not only the physician scientists and physician researchers, but the non-physician researchers?
Thank you very much. I would like to think that the general direction of travel that I've just talked about could apply equally to other colleagues. So, if you're going to run a study and you try to get some funding for an international PhD. It doesn't have to be a family doctor. It can be a health, a sociologist or a statistician, but the principle about saying, who else can we grow capacity with and through while we're doing this study, I think is one thing. Direct twinning, a lot of you as institutions may develop a link with another institution, and again, having that lens of, so who, why, where. I often get approached by quite rich institutions to partner with our university, and there's that question, so do we say yes to that because it'll be good and interesting and we'll build a partnership, or do we say no, hang on, we want to push out over here? And then who partners? So how do you have equivalents in the primary care scientist community where you can link with universities elsewhere and grow those sciences through a direct twinning? If not, maybe WONCA can also help with that, because after all, if you sort of say, well, let's talk about Kenya, I can put you in touch with my Kenyan colleagues, and they're probably looking for scientists in their own place. So I hope what I've said is generically applicable. I think it's that lens of thinking, how can we do this? And maybe doing it together, because often I think it would be true and objective to say that sometimes doctors have a voice of authority that is advantaged in society, so it might actually also be helpful for their academic primary care scientists to have them building up some momentum on their behalf, as we might do in our own departments. Let's see. Right. I think that's my time up, Mark. So thank you very much, everybody.
Thank you, Dr. Howe. That was a wonderful talk and wonderful discussion. Thank you to the audience for your interesting and helpful questions. Just a couple of comments before we go. There are a couple of special sessions at 11:45. Of course, we have many great research presentations running in parallel. There's also the Ask the Experts section, as well as the Senior Investigator Learning Community session, both at 11:45. Yoga's at 2 o'clock if you're so motivated, and enjoy the beautiful Montreal weather. And one last comment, some of you may have looked it up already. The Terrorist in My Husband's Brain was written by Robin Williams' wife about his illness and with Lewy body dementia. So that's where the rather sensationalistic title came from. Thank you.
Check.
Check.
Hello. If you're here for the NAPCRG Research Advocacy Town Hall on finding a primary care research funding home within the federal government, please come up to the front and join us up here. Otherwise, go to the back. Thank you.